afternoon, everyone. My name is Nour Al Zouabi, a first year in the EMD department. That will not save me any minutes, but to get us started today for about 5 minutes, I'll talk to you about the project I did during my time at UConn, specifically examining refugees' post-resettlement barriers to accessing healthcare services during COVID. So before starting, I would just like to acknowledge that this project was funded by the UConn IDEA grant under the supervision of Dr. Elizabeth Holzer and the guidance of Dr. Sarah Silverstein. This is a project specifically very close to my heart. It was inspired by my own family struggle accessing the healthcare system, my work at a vaccine clinic during COVID-19, where I continue to witness individuals waiting for actually someone to translate to them. And finally, involvement in programs like the Connecticut Public Health Summer Program and volunteering with various nonprofits in New Haven to kind of address all the issues that was happening and just listening to the stories of individuals continuing to struggle with the healthcare system and the failure of our healthcare system, let's say. However, moving forward, the first thing we do is just go to academia and try to search. I was specifically interested in literature about these experiences and these stories. However, to no surprise, there were very, very few that did not even include the stories themselves, but talked about them. So moving forward, I was interested in learning about the emerging barriers. While there are barriers that happen all the time, I was interested more in how they have developed, and also as well just learning a little bit more about the kind of strategies refugees use to navigate the healthcare system and what can we learn from them and improve moving forward. So even though I love numbers for this project, I blocked them before starting. I conducted 10 qualitative interviews, semi-structured interviews, allowing, no way. Okay. Okay, let's keep going. So allowing for participants to specifically mention, that actually took time. I received it back. But so the interviews, participants were actually recruited through snowballing, which was very crucial for this specific project because to ensure their comfortability and safety in actually participating. One, because safety may not be a concern to anybody here, but for refugees, it's a huge issue. Talking about anything related to systems. Again, interviews lasted between 15 to 40 minutes, age of participants, 21 to 84, allowing to capture a wide range of experiences, and years of resettlement between 2015 and 2017 to allow for conversion. So into directly the lessons learned, I already gave you the background. There is a noticeable shift that actually I saw in using healthcare services. Digital literacy was the divider between. For the 21-year-old participant that I interviewed, her language and her technology skills did not save her from the misdiagnosis that happened and led to her month-long stay in the hospital because the telehealth appointment was efficient. However, for the 46-year-old participant, telehealth was great, allowed her to save time from waiting and also did not worry about transportation. However, telehealth was only great when her older daughter, who actually speaks English and knows technology and able to follow up on her pharmacy prescriptions, was there. So with that point, the need for a comprehensive translation system is a huge thing that came out. And not only to solve the issue that the limited number of actually medically trained translators, but also to accommodate for dialects. For a language like Arabic, this is a huge issue. And on that note, nervous, worried, and anxious were some of the terms that the participants used to describe their experiences actually with using translation. Raising the concern about mental health. Michael came closer, so I think I need to end soon. But to highlight is actually like health coverage, which became a huge thing to actually the financial burden on supporting family here and back home. And finally, one of my questions was, how could we improve and what can we make better? While majority of participants was a little bit surprised, but their response was actually the need for more questions like this. There's nothing about us without us. So with that, I will conclude before Michael kick me out. But thank you all.
Thank you. Okay. Hello, I am Cristina Arnés Sanz, a first-year MPH student at the Yale School of Public Health in the Epidemiology of Microbial Diseases department. As we know, it is not a matter of if another pandemic will occur, but rather when. Therefore, the world must be better prepared to prevent a recurrence of the devastating health, social, and economic impacts that we experienced during the COVID-19 pandemic, and which are still being felt today. That is why member states of the World Health Organization started in December of 2021 a global process to draft and negotiate a convention, agreement, or other international instrument under the World Health Organization institution to strengthen pandemic prevention, preparedness, and response, also known as the Pandemic Accord. I am here today to share with you Youth for Effective Pandemic Response, a social media campaign launched by the WHO Youth Council to advocate for the healthier, safer, and more equitable world that we want, that we, the youth, deserve to inherit. Through the Yale Institute for Global Health, I have the pleasure to lead the efforts of the Yale students to support this very important campaign. And we are joining young people from all over the world, from youth organizations and universities like here. The objectives of the Youth for Effective Pandemic Response are to collect youth stories from the COVID-19 pandemic, what we lost, but also opportunities that arose. For example, many of us decided and were inspired to pursue a career in public health. We are also sharing the aspirations, how we want to see the world in the future. That is why we want governments to adopt a pandemic accord that ensures true equity for a healthier and safer world for all at the World Health Assembly in May. By raising our voices, we also hope to combat the mis- and disinformation that is flooding social media. Here at Yale, we have partnered with the Yale School of Public Health social media team, and we have a series of posts coming up in the next few weeks until the World Health Assembly. They include information about the Pandemic Accord, also student testimonies of what we lost, experiences, and what we hope to gain from better prevention, preparedness, and response, as well as a call to action for governments at the World Health Assembly. I invite all of you to join our campaign. It started as a youth campaign, but it has now grown, including healthcare professionals, other groups, faith-based communities, patient groups, so anyone can join. You can share your own stories and reasons why we need a world better prepared for future pandemics to equitably prevent and respond to this threat. You can post on social media using the hashtags below, hashtag pandemic accord, hashtag are we ready, hashtag get it done. Thank you very much.
Thank you, Michael. I'll try and do this in 5 minutes, if it's okay with you. Okay. So I'll be talking about environmental justice in Ghana and the opportunities in the rule of law and the TBLJ approach, which is the triple bottom line justice approach to achieve this. Okay, so the triple bottom line justice approach it approaches simultaneously the health, the environment, as well as the economic challenges faced by underserved communities. And this is the framework through which it achieves this. We look at the evidence-based decision-making, meaningful engagement with the community, as well as the rule of law. And this was actually inspired by a class that I took last semester, Climate Equity and Health Policy Methods, which was basically focused in the US, but I kept engaging my professor to try and see how it's applicable in Ghana, because we have a lot of environmental challenges over there. And so that's how come this international scope comes in, looking at like international frameworks that have been set up by the UN, as well as National Environmental Policy Act, which has influenced a lot of policy globally. Okay, so in Ghana, the term galamsey is a local term that describes illegal gold mining in Ghana. And this is a major environmental challenge that we have in Ghana. for a little bit of background, Ghana is one of the biggest producers of gold in the world, and 30% of that gold comes from the small-scale mining industry, and it's supposed to be reserved for the local community by law. However, we've seen an influx of foreigners who have come in with more sophisticated equipment, who are mining on a larger scale and with no interest in environmental protection or sustainable mining practices. And so we've had the devastating effects of 13 out of 16 regions currently being impacted. And the environmental impacts include massive deforestation, which has led to effects on the biodiversity, as well as pollution of the farms and rivers. And these are the farms and rivers that communities depend on. Okay, the implications are some of these farms are cocoa farms, which is another major cash crop that we have. And also the farmers are losing their jobs. There's just a general reduction in food production. To touch on some of the health impacts, we have trees that are grown in these areas producing fruits that are found to contain cyanide that is 5 times higher than what the standard levels are, the standard toxic levels are. And there's just a general rise in crime and violence in this area. Okay, please, you would have to excuse the slide. But essentially, major progress that has been made is on the side of the CSOs, or civil society organizations. They've amplified the voice of the local communities, and also the media coalitions have really brought to the fore some of the challenges such as corruption and just the high poverty in these areas that are driving this issue. In terms of next steps, the idea is to try and build more evidence that really speak on the health and then the economic implications on these communities to help support advocacy efforts, and also channel these advocacy efforts into shaping policies that not only address health, but also address the economic impacts on these communities and empowering them economically. And so Global Health is a wonderful platform to bring together different experts, legal, economic, as well as health experts, in order to support advocacy work both locally and internationally to drive this change. Thank you.
Hi everyone, so today I will be talking about the Engine Hector Ward project, which is focused on developing a non-communicable disease research capacity assessment tool in low and middle income country settings. So this project was funded by the Hector Global Health Faculty Award and has 3 key distinct stages. So stage 1 focuses on conducting a comprehensive scoping review of the literature, and our goal is to identify key themes emerging from previous NCD research capacity building programs in low and middle income countries. We want to evaluate the effectiveness of NCD research capacity building initiatives in partnerships between high-income country institutions and low-income country institutions. This review seeks to pinpoint the essential domains necessary for NCD institutions to sustain and advance NCD-related research efforts. So the second step of this study is to modify an Adelphi study. This aspect of the project will focus on having a collaborative effort between Engine faculty network members and researchers in low and middle income countries and other key experts and stakeholders. And our aim is to establish a consensus project to focus on fundamental components that should be integrated into NCD research capacity building programs in low and middle income countries. The third stage of this project is to finalize and disseminate this tool for widespread implementation. So this study started out being spearheaded by Divya Goodvali. She was the former Engine Fellow, and she worked with the support of 3 other postdoctoral fellows. And these doctoral fellows were Engine members, and since she's graduated this past May, I am now spearheading the project. So stage 1 of the project is completed, and it resulted in 21 pertinent articles being identified, where three key areas for capacity building were identified. The first being the nature of high-income country and low and middle-income country partnerships. We identified various studies of partnerships between those two entities, and those partnerships were basically around funding mechanisms. So some programs that we identified were kickstarted by high-income countries, and they were driven by high-income countries. Another aspect we identified was that grants were initiated and driven by high-income countries, and this involved low and middle-income countries applying to those grants, and high-income countries having the final say of who gets the funding and where the funding is allocated. The second key component we identified was program design and consideration. So we observed a spectrum of approaches ranging from passive to active. Some programs were online and had minimal involvement with participants, which lacked tangible deliverables. Other programs varied their focus from siloed approaches, from siloed approaches targeting specific professional groups, and others focus on multidisciplinary initiatives, while some programs were hyper-focused on particular diseases and particular professions, and they kind of bridge together the clinical and medical expertise. A noteworthy aspect we encountered was the incorporation of co-design processes in certain programs. This approach focused on collaboration between stakeholders, allowing for the development of more inclusive and effective interventions. And the third component we identified was investments in long-term and sustainable infrastructure. Our analysis revealed the importance for investing in sustainable infrastructure to ensure the longevity and effectiveness of capacity building programs in low and middle income countries. And those looked like having physical infrastructure, which encompasses establishing and maintaining necessary facilities and resources. Another aspect is training programs, which looks like providing ongoing training and education to provide and sustain expertise within local settings, and also having avenues for long-term communication and collaboration. This encompassed creating platforms and networks for faculty to have ongoing dialogue and collaboration within and among stakeholders, ensuring sustainable momentum and progress. And currently, we're working on the writing process for the scoping review and are working towards publishing it. Looking ahead, stage 2 is slated to begin in the fall of this year, and our aim is to complete that by the winter and disseminate the findings by the spring and summer of 2025. Thank you.
All right, my name is Daniel Ebbs. I'm a pediatric critical care attending and also junior faculty in the Department of Pediatrics. My training is a little different. Before medical school, my background is in community-based participatory research and community participatory program development models, specifically working with community health workers and extremely rural, underserved areas to create self-sustaining and sustainable models that are kind of targeting their own development and education. Community-based participatory research is something that is very unrecognized in global health research. Partially because, like this lightning talk, it takes a significant amount of time. Unlike this lightning talk, takes a significant amount of time to co-develop research programs with local communities. So it takes a lot of resources and time, obviously. The programs I work with are in northern Uganda, northern Guatemala, and the northeast Peruvian Amazon. Specifically, I want to talk about a program in northern Uganda, a project that we have been working on over the last few years. The program started about 10 years ago. Northern Uganda, about 7 to 10% of children in this region that we work don't make it to their 5th birthday. More than half of these children die at the community level. And there's no real way, aside from the WHO expert consensus on identifying danger signs, to triage these children early. Although there are several risk prediction scores that are used in rural clinics across the region, nothing's translated to the pre-hospital setting. On top of this, ubiquitous to the area is asymptomatic malaria and around 50% or more children, in addition to nutritional deficiencies. And so because we have this community-based program, and because we have the infrastructure that's developed there, we've been working with community health workers to figure out a way that we could create a pre-hospital predictive model to identify seriously ill children early in the pre-hospital setting. This could not be done, I feel like, without this type of program, just because the level of the sample size that we need, in addition to the type of training, would be really difficult to just go in. And so I think having a community participatory framework has really given us an edge to conduct initially a pilot study with the communities there that they co-developed, and then right now we're finishing the subsequent larger study to see what different clinical variables can identify which children are at high risk for serious illness. Yes, I think that is it. And if anyone's interested, we have community participatory program models in several different countries, and we're working with communities and community health workers to develop research capacity and those other sites that I mentioned. Thank you.
Hi everyone, I'm Tharani. I'm a second-year student in SBS, and today I'll be talking about my research with the ERIC Lab, the Equity Research and Innovation Center at the Yale School of Medicine, on the associations between sugar-sweetened beverage consumption and the frequency of eating food away from the home in the Eastern Caribbean region. So there's two main reasons why I think this study is very important. One is that SSBs, or sugar-sweetened beverages, so that's juices, sweetened milk, Coca-Cola cans, all the stuff you see at grocery stores, represent the highest consumed category of ultra-processed foods, which have been implicated with the rising prevalence of NCDs like type 2 diabetes and obesity in many regions, especially the Eastern Caribbean region. The second is we generally have very limited data on chronic risk factors in the Eastern Caribbean region. Chronically, we tend to clump together Latin America and the Caribbean. Even a lot of UN organizations are structured that way, and there's chronically just very limited data collected in the Caribbean region. So I'll be very brief with the methods, but essentially what we did is we conducted a cross-sectional analysis of baseline data that included around 3,000 adults in these 20 different regions in the Eastern Caribbean region. This data was collected from 2013 to 2018, and we used a multivariable logistic analysis to find that, in fact, frequency of eating outside the home was associated with sugar-sweetened beverage consumption. Now, the main implications of this research is, as mentioned by the faculty in the fireside chat, NCDs have been chronically underfunded in research, so it's always good to see more NCD-related research, especially in Eastern Caribbean regions where they represent the leading cause of mortality. Second is that, as I mentioned, there is very limited data in Caribbean regions. And third is also from a more global standpoint, moving away from blaming individuals for consuming SSBs, many big soda companies use very exploitative marketing techniques to really push SSBs in under-resourced regions, and this disproportionately impacts youth and different vulnerable groups that tend to consume SSBs more and are more impacted by NCDs. Yeah, that's all. Thank you.
Hello, my name is Cristina Panzer. I'm a psychiatric mental health nurse practitioner student at the Yale School of Nursing, and I'm presenting on my project about investigating culturally sensitive solutions to childhood substance use in the calm Indigenous community of Argentina. So this upcoming summer, I'll be traveling to Formosa, Argentina to conduct this project I created in collaboration with my mentor, Dr. Claudia Valegia. And Dr. Valegia has a long-established relationship with the COM community in Formosa, in which I will be conducting qualitative research. So when I first met with Dr. Valegia I'll move on to the background about my project. When I first met with Dr. Valegia to discuss a project, she was really excited that I was interested in mental health research because the community there had reached out to her about an emerging issue, which is childhood substance use. Specifically, glue inhalation has become a really common practice among school-age children, which poses health and safety risks clearly to children and the community. It not only hinders kids' ability to be alert and make safe decisions in the moment, but glue intoxication can lead to long-term psychological and health risks. There have even been cases of kids who have passed away overnight related to glue intoxication due to falling asleep on the street on a cold night. So my plan is to conduct a research project that would shed light on culturally sensitive interventions, which means I want to assess where people go for healthcare, who they trust in the community, where kids are. There are multiple different types of healthcare treatments within the community, places people go. For example, there are biomedical Western centers, but there are also traditional healers, and some people may go to other sources, such as the evangelical church, to seek advice related to healthcare or mental health. So my project consists of two main phases. First, I'll conduct interviews and surveys with adults in the community, beginning with the community leaders. This may be leaders of the health center, school teachers, religious leaders, anyone else who is recommended to me. In the next phase, I'll be observing children, focusing on those between age 6 and 13 years old. And I'm considering conducting short interviews with children, but this interview portion is still under IRB review. I believe one of the biggest takeaways from designing this research project has been navigating the cultural differences and IRB review process in what is ethical in our Western biomedical setting versus what is ethical to the COM people in their cultural setting. So in the culture of Baro Nam Com, children over the age of 2, age 2, are viewed as independent and capable of making their own decisions. They make decisions regarding their health care, their education, where they live, whether or not they attend religious services, and how they choose to spend their time. So in the setting of this culture, consent to participate in an interview would come from the children themselves, not from parents. And in Formosa, there is no IRB that would review this study. The Yale IRB is the only entity that I go through to approve the ethics of this study, and this is something that Dr. Valegia, my mentor, is working on setting up some sort of ethics review board in this community, but the infrastructure just isn't there yet. And so it's been really interesting to think about that there is no black and white of what is ethical and not ethical when ethics are set in the context of our Western culture, which doesn't apply in Baro Nam Com. So my current plan for the study is to meet with community leaders when I'm in the field and discuss the benefits and risks of interviewing children and how to best collect consent in the context of this culture. So I am also working closely with researchers that work in the field to make sure that my plan is sustainable and that they can build off of the work I do after I leave. So I plan to analyze data through NVivo software, create a code book when I'm in the field, and share a preliminary report with community leaders and study participants before I leave, and then share more information once I'm back in the States and I'm able to create a more advanced report. So I'm grateful for this opportunity to learn through this research, creating the proposal, and learn more when I'm there over the summer. And thank you all so much for listening to my project proposal.
Hi, everybody. So, see if I can make this advance. Something will make it advance. See, nobody else had a problem figuring out how to make it advance. All right. Next. There we go. I really can do something. So, what's wrong with your data? If you're getting it from hospitals, it's often low quality, but it's what public health sort of relies on. So all the way on the left is 20 years worth of cases of children who needed surgery of the brain because they have water building up from neonatal sepsis. We actually just characterized where this was from. But is it really just two hot spots? Careful. The hospital is right here. Okay, so if you looked at what's the distance to that hospital, this disappears, this doesn't, and is all this out here really okay? It's not. So how do you go about addressing, this is a little bit of a riff on the community talk that you just heard a few talks ago. And so what Daniel was talking about is putting a sentinel, for instance, in every village. We have a project now to do for 18 months exhaustive community level surveillance in a piece of the kingdom of Busoga, 559 villages with a trained village health team leader to record every case. Why do you want to do that? First, obviously, you want to know what's going on out there. Second, if you want to prevent disease, how do you know you did any good? These infants die fairly early in life. And in countries with high infant death rates, it can go unnoticed. So there are methods of developing adaptive surveillance. Does some idiot really have to put a person hired in every village? Maybe you only need to do every second or third villages. The techniques have been developed in public health. Peter Diggle has for years in England worked on techniques to do adaptive surveillance because nobody can do it exhaustively. What can we do with preventable neonatal death? You want to know the risk, but the risk you're going to calculate from cases popping up, you can't really touch. You have to calculate it, and it's uncertain. You want to pick a threshold if your resources are limited to say, where do you put your precious resources when resources are constrained? So that's the whole goal of this, and to use it as a model for how can you adaptively survey and optimally control such disease in other settings. Take-home message, hospital data bad, village data good, too expensive. Can you use science to raise enough money from well-meaning agencies to test out how to more optimally do control? And that's what we're doing. Thank you.
Hi everyone, my name is Melanie Syan. I'm a trauma and general surgeon here at Yale and an assistant professor of surgery. And
my name is Paul Serrato. I'm a medical student here at Yale.
So I've been in partnership with surgeons in Malawi at Kamuzu Central Hospital for many years, doing work, both clinical research and education. And so recently we've decided to sort of focus our energies on quality improvement work. And so that is what we are going to just briefly talk about today. So the first thing I'd like to say is that, all of this global health research, if you're not actually from these communities or not actually living and working in the various hospitals or communities, I think it's important to work on transparency, equitable relationships, and ensuring that there are bilateral benefits that are tangible. And so through this work, partially, I think we were able to help get one of our partners a really prestigious scholarship from the American College of Surgeons, which I'm proud of and he's proud of. And also through all this work, we focused on being open and having open conversations about authorship, in particular first and last authorship positions. And that is something that I hope to continue to do through my work at KCH. And so the other part of this work, quality improvement work, has been embedding research education into the process. And so we've done this in a few ways. One was I have offered a qualitative research course, which was taught by mostly Yale folks here. So if any of you are here, thank you very much for your time and energies, as well as offering a statistics course. And we do have research meetings to reinforce and teach research principles. And so the first quality improvement project that we embarked upon has been Paul's project, and it's a systems improvement concept where we are trying to decrease the rate of surgical case cancellations that are canceled on the same day of surgery. And so Paul can talk about some of his accomplishments with that project and the basic framework.
Sure. So the first thing that you should know about this project is that our Malawian partners are the ones who really identified this issue as a key issue for us to investigate at their hospital. And it initially started as a Downs Fellowship project that I started this summer after my first year of medical school. And since then, I've been able to kind of continue growing that project. And overall, it's been a very enriching experience because as a student, it's been an opportunity for me to learn not only qualitative and quantitative methods, but also learning how to communicate my results to a wide variety of audiences. So as you can see on the screen, I've been able to present this work in a variety of venues, including the 19th Annual Academic Surgical Congress, as well as the Boateng Roundtable, just to name a couple.
And so this work, so Paul's time is sort of coming to a close, and so we've now opened up a next chapter where we are following up the patients that had their surgery canceled and seeing what happens to them, what complications, if any, are they having, what network do they fall back on, is there a safety net that we can kind of sketch out and map, and sort of an access for patients that are having difficulty getting their surgery at KCH. And so this particular project culminated with myself being able to give grand rounds at KCH to a multidisciplinary group of the anesthetists, the hospital administrators, nursing staff, and the surgical staff, as well as medical students. And so, yeah, go ahead.
So in conducting qualitative and quantitative studies on the issue of case cancellation, we were able to develop a process map to fully characterize the perioperative process at KCH. This is something that hasn't been done before in this setting, and so in interviewing key stakeholders at KCH, we were able to formalize a specific document that helps us identify specific areas where we can target to help reduce overall cancellations in this setting. And we did that both through qualitative and quantitative methods. So the diagram on the right, you'll see specific regression analysis results that helps us identify specific factors that would most impact cancellations.
So these are just a few pictures of myself and Paul doing an operation on call one night, our research team members and myself giving grand rounds. And so in conclusion, I do think we are doing capacity building with our research education efforts. While the system may seem chaotic, there is a system that does exist, and so I think it was possible for us to identify targets for interventions. I do think quality improvement work I'm learning is actually particularly challenging for a foreigner to champion for a whole host of reasons, and relying entirely on my local partners to champion something that is adding on to one of the many hats they're already wearing can be difficult. And then lastly, I think ultimately this data can be used for resource allocation and discussions with the Ministry of Health, and that's ultimately our goal.
Hi everyone, my name is Emma. I am graduating pediatric fellow, and I'm going to talk to you today about my work looking at travel surveillance, discovering previously unreported dengue outbreaks and viral introductions in the Caribbean. So really, we all know that dengue is a major public health concern in the Caribbean. We have local surveillance that's really essential to responding to these outbreaks, but it's challenging in low and middle income countries, especially where outbreaks can overwhelm health systems. So in these areas where we have limited available data, we need something to help supplement that. And what we can do is we can use travel surveillance data. What's great is that the Florida Department of Health has a really robust dengue surveillance system that captures symptomatic cases in infected travelers. And so we were hypothesized that we could use this surveillance of dengue-infected travelers that were diagnosed in Florida who had recently returned from the Caribbean to better reconstruct dengue dynamics in the region. And so what we did is we constructed this model to predict local infection rates from travel rates. And we know that the Dominican Republic, Jamaica, and Puerto Rico have robust local surveillance. You can see those in Part A. And so we use them as predictors due to their strong correlations with local and travel-associated cases. when we then applied our model to Cuba, we uncovered a large outbreak in 2022, similar, which was interesting because the country had only reported around 3,000 local cases, but we had almost 1,000 infected travelers returning to Florida. So we then compared our predicted infection rates to others that are observed and reported in South America and other areas in the Caribbean from 2009 to 2023. And what we're able to see is that, so these dots are outside of the 95% confidence interval, and they represent large outbreaks. And we can see again that this large outbreak in Cuba in 2022, that's reporting about 1,000 cases per 100,000 of the population. And it's the largest that's been detected on the island since 2010, but it's similar in size to other local outbreaks that have been seen throughout the Americas. So we then sequenced some of these cases and performed phylogeographic analysis that showed that this large cluster here of dengue 3 sequences from Cuba in 2022 is from a recent introduction from Southeast Asia that likely occurred in late 2020. And using data from the Florida Department of Health and from the CDC dengue branch, we've shown that this lineage has actually already been detected in in Puerto Rico, Florida, Arizona, and recently was detected in Brazil. So given the speed of these events, it seems like it has significant transmission advantage. So overall, when combined with genomic epidemiology, we can use travel surveillance to provide a snapshot of diversity in the Caribbean, as well as reveal patterns of emergence and lineage spread. However, obviously, that utilizing infected travelers cannot replace local surveillance, but can be helpful for where we don't have great local surveillance or it's underfunded, with helping uncover blind spots, providing a global snapshot of genetic diversity, and detecting things like new introductions. And so by using travel surveillance to supplement local data, we can detect these local outbreaks and help estimate their size. And overall, this can help these countries with responding to outbreaks. Thank you.
Good afternoon, everyone. My name is Chantal Vogels. I'm one of the co-leads of the Yale Vector-borne and Zoonotic Diseases Network. So I'm going to give an overview of our network and highlight some opportunities for you to get involved in the network. So if you go to the Yale Institute for Global Health website, you can see that there's 14 really fantastic faculty networks. They're all centered around specific themes. And we just launched our network last year, and we're really aiming to bring together people interested in vector-borne and zoonotic diseases. Especially because we're kind of scattered across different departments, different schools, and we really wanted to create this network to bring people together and foster collaborations. So I'm co-leading the network together with Dr. Sarab Aksoy and Brian Weiss, and we are organizing quarterly meetings. And we've now organized an annual symposium twice in this room where we, again, really want to showcase all the exciting research that's happening. So our network goals are, again, really to promote all the exciting research that's happening here at Yale, especially across campus, and really stimulating new collaborations, building those bridges between different departments, bringing people together. We're also aiming to secure research and training grants to really create opportunities for students, postdocs, trainees to get involved. We aim to enhance career development, and we create and share facilities and resources, again, really to help each other out and really move our research forward. This is really just a snapshot of many of the faculty that are working on vector-borne and zoonotic diseases. And there's really exciting research and training programs all over the world. I'm just highlighting a couple of those sites here. And I definitely encourage any students, postdocs, trainees, even faculty, if you're interested in either getting involved, collaborating, Feel free to reach out to members of the network, or feel free to reach out to me, Sarab, and Brian, and we can definitely help you make those connections. We have our next network meeting coming up next month, so May 10. We have two fantastic speakers, Drs. Andrea Gloria Soria and Dr. Brendan Ugbunu. This meeting is going to be themed Vector-borne zoonotic disease, ecology, and evolution. It's happening at main campus. If you're interested in joining us, either for the meeting or just in general getting involved in the network, feel free to reach out, and yeah, we're happy to welcome you. Thank you.